Good morning. This is the Incarceration Prevention and Reduction Task Force Joint Behavioral Health and Legal and Justice Systems Subcommittee. It is 11:32, December 13th, 2022. I'll start with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lumming, Nuksack, Samish, and Samiama people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection all across barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. All right. Call this meeting to order, and the first item on the agenda is the 988 mental health crisis line from the Behavioral Health Committee. The presentation is going to be by Courtney Caldwell. Sorry if I said that wrong. I hope I did it right. And she's the program manager for Volunteers of America, and possibly joining her today will be Mia Flick and Clarissa Youngweiser. I'm going to turn that over to you, Courtney, so you can inform us on all the wonderful things you work with. Thank you.
Thank you very much, and thank you everyone for having us. I'll start with a quick introduction. So, like she said, I'm Courtney Caldwell, 988 Operations Manager at Volunteers of America, Western Washington, and Mia and Clarissa, if you both want to jump in with a quick introduction, and then we'll get going.
Okay, I will go. I'm Mia Click. I am the Native and Strong Lifeline Coordinator here at Volunteers of America, Western Washington.
And I'm Clarissa Youngweiser, the Tribal Hub Coordinator for the Washington Indian Behavioral Health Hub at Volunteers of America, Western Washington.
Okay, thank you both. And let me share my screen. All right, so we heard this group would want to hear an overview of how 988 and other crisis programs we oversee work. So we can start with an overview of all of our crisis services to differentiate between 988 and the others. So at Volunteers of America, we operate the regional crisis lines for Greater Columbia, North Sound, and Salish regions in Washington State. So that includes Whatcom County, and we also answer 988 calls for 32 counties in Washington and 988 chat and text for the entire state. And we also do 988 national backup chat and text services for the rest of the country. Our tribal programs that Mia and Clarissa will talk about include the Native and Strong Lifeline and the Washington Indian Behavioral Health Hub. And last, we have the North Sound Crisis Follow-Up Program. So we wanted to talk a little about what sets 988 apart from the regional crisis lines. This is a question we get a lot. And the main difference between 988 and the regional lines is that 988 is an easy to remember access point for crisis services, while the regional lines can offer more specialized local support, like dispatch of mobile outreach teams and designated crisis responders. So 988 is not replacing that current system of regional crisis lines in the state. Those regional crisis lines are contracted through the HCA and administered by the BHASOs, and crisis centers subcontract to provide 24/7 crisis services. So the BHASOs are the ones responsible for providing that designated crisis responder outreach and the mobile crisis responders for community support. And some BHASOs will contract with crisis centers to dispatch those mobile teams. So that's what we have in North Sound. And then the 988 centers are appointed by their state. They're required to be accredited and contracted with the National Suicide Prevention Lifeline, also known as Vibrant. So VOA has been an accredited Lifeline center since it launched in 2006 and continues as a 988 center. So what changed with 988? It is not a new crisis line, but it is a new way to reach the National Suicide Prevention Lifeline. The 988 network is made up of crisis centers around the country, and the 3-digit number is a new access point. So those calls are continuing to be routed from New York, where Vibrant is headquartered, and sent to the state assigned to the caller's area code, just like they have been historically. So the crisis centers that were answering the 10-digit number are continuing to take the same calls that now reach them through 988. And the 10-digit number, as well as the even older 1-800-suicide number, still work and will work for the foreseeable future. And very exciting, as of July 16th, individuals are now able to reach the 988 chat and text service by texting the 3-digit number. And they also have the ability to chat online. So there were a lot of reasons why transitioning to a 3-digit number that's easy to remember is important, and received a lot of legislative support, especially in our state. So suicide is the 3rd leading cause of death for youth under age 15. The 2nd leading cause of death for young adults age 25 and under, and it is the 10th leading cause of death for all people in Washington state. So 988 creates an easy to remember access point for reaching potentially life-saving crisis services, making help much more accessible in a crisis. If someone needs it, they don't need to go look it up. They don't need to go find where the card they were given is. They can just remember 988. And we were also really fortunate in Washington state to have experienced a vast increase in crisis center funding, which allows us to have trained counselors available to answer calls, chats, and texts immediately as often as possible. So to give a little more information on our 988 services here at Volunteers of America, we answer those calls for 32 counties in Washington shown on this map, and that includes all of Washington state except for King County and a handful of counties in Eastern Washington. We are the only chat and text center in our state, and we provide 24/7 988 chat and text services to the entire state. We also provide national backup chat and text services. So that means we can answer chats and texts that are not answered locally in other regions of the country. And the chat and text service is a great resource for youth. Over 50% of all clients accessing the chat and text service are under the age of 15. And 988 really has a lot of different uses. So we see it primarily client facing, but providers could also call with the client just for the introduction, so the 988 counselor can explain how it works and hopefully make the client more likely to use it when needed in a crisis. It can also be a resource for concerned family and friends who just need to know how to talk to someone about suicide, how to connect them to resources, or just general information on how the mental health and crisis systems work in our state. So someone can call or text 988 before they're having thoughts of suicide, and we really encourage people to call as soon as possible. We operate under the philosophy that crisis is self-defined, and a bad day and needing to talk can constitute a crisis. And our counselors can work with them on proactive ways to intervene in a crisis if one develops. And then, of course, individuals in active crisis with active thoughts of suicide can definitely call or text 988 if they feel they're unsafe. And our counselors will work with them on an intervention starting with least restrictive measures and only escalating to more restrictive if the safety assessment deems it necessary. So our North Sound Crisis Follow-up Program currently serves the North Sound region, provides light case management and short-term supportive listening and follow-up services. We're also using certified peer counselors in this service, which has added a lot of value to our service delivery, and that's something we would like to see expanded to all of our programs. The eligibility criteria includes being a resident in the North Sound region, consenting to receive follow-up services, and having access to a phone. So to reach this program, a client would contact the North Sound Regional Crisis Line, and the counselor would refer them to the program for intake. So this could be a great resource for clients to use if they're waiting to receive other services. Could also be a good opportunity to create a safety plan with a counselor using best practices and have someone to check in with daily, weekly, whatever is needed to revise that plan to make sure it's something that'll work for the client. So now I will hand it over to Mia and Clarissa to talk about the Native and Strong Lifeline and the Washington Indian Behavioral Health Hub.
Thank you, Courtney. Okay, again, I am Mia Click, Native and Strong Lifeline Coordinator here. So this will be an overview of the 2 new Native-driven programs here at Volunteers America that we have, the Native and Strong Lifeline, as well as the Washington Indian Behavioral Health Hub. And hopefully we'll have some time after this for questions or comments. Next slide, please. So what is Native and Strong? It's the first statewide crisis line for Native Americans and Alaska Natives. It operates just like Lifeline, meaning we operate 24 hours a day, 7 days a week. Our tribal crisis counselors that answer the phones are all answered by, they're answered by other natives. So they're not all enrolled. There are descendants as well, but they're all advocates for their communities. We're really excited to say that we have counselors here in Washington, California, Arizona, and Alaska. Next slide, please. So I'm going to go out on a limb here and assume that everybody knows that suicide disproportionately affects Native Americans and Alaska Natives. Death by suicide among Native women is up 139%. From 99 to 2017. So just think about that. Just let that sink in just for a second. Suicide is the second leading cause of death for American Indians and Alaska Natives, and the highest rate of suicide among our young men between the ages of 10 and 34 years old. All these numbers tell me is that our young people are dying, and haven't had many places to turn in the past. Nowhere that understands the barriers, the pain, and the suffering, and that's why we are here. That's why this line is so needed. Our Native communities need to know that there are people here answering the phones that will be able to hear them with the knowledge of what they're speaking about. We don't have to educate them to get help. So this is extremely important, as building rapport is quite difficult to do in communities, in these communities, which are very hesitant to trust state programs. Next slide, please. The thing that makes us unique. So again, Native and Strong will be it is the first statewide American Indian Alaska Native specific suicide and helpline. So there are several tribes that have their own crisis lines throughout Washington state, and the Native and Strong Lifeline is not meant to replace those lines. We want to support those lines and just be another resource for them. So our all Indigenous staff do complete the standard crisis counselor training here at VOA, but with the added Native specific training modules that I was able to create and add in with the assistance of Courtney. The counselors will answer the phones with their tribal affiliation, and that is to help start building that trust, like right from the get-go, leaving it open for the client or the caller or the relative to feel comfortable knowing who they're speaking with. Next slide, please. So the things are the same, like I was saying, it operates 24 hours a day, 7 days a week. And this is important that we are operated on a 24/7 basis, because no one gets to choose when they go into crisis. And more often than not, it happens in the middle of the night. I've been through a lot of crisis in my life, and it always happened at 3 o'clock in the morning. So it's really important for us to have that 24-hour line, and we have enough barriers as it is. This line's hours didn't need to be another barrier. The counselors do go through all the traditional crisis counselor training, like I was saying, as well as cultural competency training, which is made up of modules packed with everything from etiquette do's and don'ts on the phone to communication styles. They complete personal assessments as they move throughout the training as well. And can Native and Strong complete referrals and transfers? Yes, we can. We operate just like Lifeline in that way. Next slide, please. So who can access the service? Any tribal affiliated person in Washington state can. So this does not mean exclusively enrolled members. This means American Indians, Alaska Natives, First Nations, enrolled members, and descendants. This service is indeed not specific to any one Washington state tribe, but is inclusive of all tribal people in the state, whether their tribe is located in Washington or elsewhere. So this was something that I was so happy to be a part of, as I come from a family myself that is half enrolled and half not. And this is very common in Native communities. So I'm very proud of the fact that no one's going to get turned away from this service for not having a plastic enrollment card. It was a big thing for us, and I'm excited about it. Next slide, please. So accessing it, and good things take time, and I swear this took so long. But it's my absolute privilege to say this out loud and know that it has happened. we are in it and we have kicked off. So as of November 10th, Native and Strong is accessible by dialing 988 and choosing option 4. Our team worked very closely with Vibrant to make this happen, and it's in large part to our tribal operations manager, Rochelle Williams. She fought really hard for a dial pad option and to be a true part of 988 and not settling on a long 1-800 number. And she knew how much we needed to maximize accessibility. So she insisted on being a dial pad option, and I thank her every day for it. So right now we encourage all of those needing support to contact 988, and someone will be there to answer the call, and option 4 is there, and we're excited about it. Okay, next slide, please. I will hand it over to Clarissa from here. Thank you, guys.
Good morning, everyone. I want to give you a little rundown on the hub and what we do. Our program manager, Rochelle, once compared us to 211. We're very fortunate to have access to everything that the VOA has to offer, as well as culturally relevant options such as sweat lodge, powwows, coastal jams, and traditional arts and crafts. Next slide, please. The hub was developed to address the need and support Indian healthcare providers and tribal governments and urban Indian health programs to navigate the complex behavioral health and crisis systems. We offer tribal resources and information, as well as resource information from outside entities throughout the state for Native Americans, Alaska Natives, First Nations, and their descendants. Next slide, please. We're working hard to keep our networking and resources relevant and up to date to give our callers the most current support, including but not limited to finding inpatient facilities, behavioral health and substance abuse, connecting to legal assistance, utility and energy assistance, vocational rehab, housing resources. And in our culture, many of us hold our elders to the highest and utmost respect based on their knowledge and wisdom. And I think it's also important to note what the hub does not do. We do not provide or have direct access to crisis services, such as psychologists and therapists. If someone is in crisis, they should call 988. We do not have direct access to treatment beds, and we do not have foster placement capabilities. Next slide, please. In this slide, you'll see the call flow and what callers should expect when they call the hub. They will call the hub, be connected to a navigator, explain what resources or information you might need. The hub navigator will locate the resources and pass the information along to the caller and follow up if needed by the caller, needed or wanted. Next slide, please. Takeaways: the Native and Strong Lifeline went live November 10th. It's a 24/7 service in Washington State, accessible through 988 by dialing option 4. The hub is operating and ready to receive calls. It's a resource line for Native Americans and Alaska Natives. Both tribal and non-tribal resources are provided. Next slide, please. And here's our contact information, and I can put it in the chat.
Thank you, everyone, for listening. I'm not sure if we have time for questions, but we're happy to answer questions if there are any. And I'm not able to see the people or the chat. So if you want to just come off mute and let us know your question, that would be helpful.
I have a question. This is Brian Estes. How do you deal with somebody, say, who lives in Washington but has a cell phone number in Florida? How do they get directed to the right place?
Yeah, that's a great question. So I will say a long-term goal of 988 is to implement geolocation routing, but we are not there yet due to limitations of the technology. So there is a national standard among 988 centers that if you get someone from outside of your area, you will resolve the immediate crisis, make sure they're safe. And then if they would benefit from some local resources, you'll do a warm transfer to their local crisis line. So it's not a perfect process. It's something that we hope to see improvement in as we do get those geolocation routing features, but we do have a way to work with it right now.
Mike Parker?
Yeah, thank you all for your presentation and really also especially glad to hear about the Native and Strong edition. I was curious about the follow-up. You said that was specific to North Sound, so that doesn't sound like that's a 988 feature in general. Rather, that's one specific to residents of the North Sound. Did I get that part right?
Yes, you did. That's a North Sound funded program that serves the 5 counties in the North Sound region. I will say that follow-up is also a long-term goal of 988. So that's something I wouldn't be surprised to see expanded to other areas of our state.
Great. No, it's a really helpful thing. And as a clinician helping folks and sending them to a line, I think that's absolutely critical that they get follow-up. It sounded like that would not transfer though directly from the 988 line. Is that correct? There would be a secondary step to request follow-up.
So we can make referrals from the 988 line. The North Sound crisis line only serves North Sound. So we know every caller who calls that is typically eligible, where with 988, we're serving 32 counties in Washington. So it's just a much smaller percentage of people that reach us on 988 that are eligible for the follow-up service.
So a person could, if they're calling you, they have the right phone number, say it's 360 and they get routed correctly to you all, they could request follow-up while they're talking to one of your counselors and be connected that way. They wouldn't have to make a second step. Did I get that correct?
That is correct. And same with chat and text. If someone reaches out to our chat and text service and they meet the eligibility criteria for follow-up, they can be referred to intake by that counselor as well.
Okay, super. And then I suppose then one of the questions, then a follow-up question to that follow-up was, you were very clear that you don't necessarily have a special hook to get somebody into an appointment in front of a prescriber, if that's one of the issues. What kind of services and follow-up do you offer? Is there facilitation, for example, to get somebody with one of our Medicaid providers, or what kind of things are offered in follow-up for somebody?
So it's typically very light case management. So the follow-up counselor will work with the individual to determine what services might be needed. The follow-up counselor will identify the best way to reach those services. They'll set up goals with the clients to say, okay, you're going to try to contact them this day, and then I'm going to call you later that day to make sure you're able to get through. And if you weren't able to, we can strategize what to do next. So it typically works that way. And the resources that are provided are really, they vary quite a bit depending on what the client needs.
Okay. And then I don't know if you have other people waiting because I can't see either. And then my last question, and I really appreciate all of your answers, but when you didn't talk about it or in the Native and Strong one either, but if, your operators have concern, what does it look like for you all to reach out to law enforcement for welfare checks? Or maybe could you talk about that at least briefly, what that might look like?
Yeah, so that is very rare. It happens in less than 2% of all of our interactions. And it's when we identify that someone is unable or unwilling to safety plan and they're at imminent risk for suicide. It's really something we do really if we think that they will die if we don't. And typically what we'll do is the counselor on the phone with the person or on chat or text with them will reach out to a colleague and say, I need a police intervention or welfare check. We kind of use those terms interchangeably, and then they will stay connected with the client as long as possible while a colleague reaches out to law enforcement for help. And when possible, we try to do a warm handoff where when the officers arrive on scene, our counselor will ask, could I talk to them on your behalf? We try to make all this collaborative whenever possible.
Great. And thank you for answering so many additional questions, and thanks for what you all do.
Oh, thank you.
Thank you, Courtney. Mike, I believe Dan Hamill has his hand raised.
Thanks. Mike stole my thunder a little bit in terms of the what happens if it's an involuntary commit. So I'm glad, thank you for answering that question. That's great. I'm wondering, so Bellingham is deploying an alternate response team sometime in early 2023, and that response team will be a more immediate response to behavioral health, a person who's in behavioral health crisis. I'm wondering how Volunteers of America and the programs within the 988 system see the interaction with these kind of local programs that are meant to help intervene in behavioral health crisis.
Yeah, so that is something that we already see that in various forms in our regional crisis lines, like we'll dispatch mobile crisis units, dispatch designated crisis responders. So we are expecting to see a lot of growth in that area, like you mentioned with this new program. So that's something that our regional crisis lines will mostly work with. So if somebody reaches out to 988, because since we only do the regional crisis lines for 5 counties in North Sound, 9 in Greater Columbia, and 3 in Salish, we're not hitting the regional crisis lines for all 32 counties where we answer 988 calls. So that's why we have the process of identifying what's needed with the client, warm transferring to the regional crisis line, and working with the counselor on the regional crisis line to get those services out to the client. And I know it is a goal of House Bill 1477 to have some rapid response units. So it kind of sounds like that's kind of in the realm of what the state is hoping to happen. I'm not sure if that answered your question or if that was just a lot of babbling non-answer.
No, that's fine. I'm just trying to get a sense of the services that are available to folks who are undergoing these these terrible behavioral health crises, and what resources, like where does a person go if law enforcement intervenes and there's an involuntary commitment component. I guess in Bellingham and Whatcom County they would go to one central at St. Joseph's Medical Center, but that's only got, I think, 10 beds, and Mike Smith might, and one of the others on the call might know a little bit better than I would in terms of where do people go? How do they get better? What are the resources if they don't want to, somebody calls on them or regarding them? I guess I just want to understand how that works more fully.
Yeah, and that really is, I mean, the question we all want the answer to is how do people get better? And unfortunately, bed capacity can be a big issue, especially for youth. I mean, youth psychiatric beds are almost non-existent. So we do conduct twice daily a bed census. So we have a general idea of where there are open beds, and we can give that information to the designated crisis responder or the mobile outreach team arriving on scene. So I'm not sure if I'm not sure how in depth I'd be able to answer what happens after that. We kind of just see the initial dispatch aspect of it.
And then I just have one more follow-up question. What is the response time for a mobile crisis outreach team or DCR? What is typically after the person calls 988 and says, look, I'm in the middle of a crisis, or however they phrase it, what's the response time that you're seeing in terms of getting to that person?
Sure. So we dispatch immediately, and I believe that the WAC specifies a 2-hour response time. But again, that's what happens after we dispatch. So I can't necessarily speak to if that's happening consistently or what the average response time is.
Yeah, Dan, we might want to have somebody from the ASO, like Michael McCauley, come and give you some specifics regarding data and all of those issues about how people are transported. But the DCR looks for a bed, and then generally they're transported. And I think the hospital does the transportation, but he could answer a lot of these questions and bring some data as well.
I think that'd be helpful. As 988 rolls out, I get these questions all the time in terms of, how does it work? How is it different? And it's, and this has been a very helpful presentation today. So thanks to you and your team for coming today. We really appreciate it.
Thank you.
Courtney, I don't know if you have time for one more. I did have another one. And I think, you know, as a clinician that's worked with folks, every once in a while, we wanted a service that would reach out. And I don't know if 988 even has that or if that's ever in the future, but as a proactive service, meaning let's say as a clinician, we could say we have a person of concern. Could we call and ask for a reach out? Is that something that is possible, number one? And if it's not, is there any talk of doing such a service, or would that only be for folks involved in your follow-up program that you mentioned?
So for a one-time phone safety check-in, that is something we currently offer on 988. Anyone, it could be a friend, family member, provider, anyone can call in or text or chat and say, I'm really worried about this person. Could you please give them a call? And our counselors will do that.
Thank you much. And really appreciate your presentation, all three of you today.
Well, thank you very much for having us. Any last questions?
Courtney and Mia and Clarissa, I'd like to say thank you on behalf of everybody in this committees. I'd also like to know if there's any gaps, resources, or needs that we could be of assistance in.
You know, I think, and Mia and Clarissa, you're welcome to speak to this, but I think now that the Native and Strong Lifeline has launched, we want to make sure people know about it. So if there are any community partners you'd like to share that with that could find it beneficial, that would be a huge help.
I guess the only other question that I would have for you is I know a lot of youth and individuals may not have cell phones, and obviously we don't see phone booths like we used to anymore. Do you ever partner with places that would have phones available for youth in crisis, whether it would be a laundromat, a school, you know, the hubs that you guys were talking about, those areas that if there was somebody in need and didn't feel comfortable going to a parent, that they would have a phone that they could reach out to you with?
You know, we don't necessarily partner with places that use things like flex funds to give phones, and we don't use flex funds ourselves. But something we do is we will partner with local schools and suggest that the school counselor have a computer available in their office that a youth could reach out to our text and chat program. So I think there's opportunity in areas like that for us to explore things like that. That's definitely a barrier that we see, especially for youth. So yeah, kind of a non-answer, yes and no.
That's all right. Thank you. I really appreciate you guys presenting today. I don't see any other hands going. Alrighty, thanks again for your presentation and answering all the questions for us. We appreciate you.
All right, thank you so much. And we'll send out this PowerPoint in case you all want access to it, and feel free to contact us with any questions.
Excellent. Thank you.
Okay, thank you.
Thanks so much.
And the next item on the agenda,
Have a good day, everyone.
thank you, is our competency evaluation and restoration work group. And I'm looking out there for Maya and Perry. I saw Maya earlier, but she has disappeared from us. Is there anybody else here that's on the competency evaluation restoration work group that would like to speak on their behalf?
I'm sure willing to, Raylene. I feel like I'm that one raising my hand and the teacher is saying anybody else at all, but no. I'm just kidding.
Thanks, Perry.
Maya actually emailed me during the presentation from VOA and indicated that she had to go to another meeting that, interestingly enough, is actually related to the work the competency work group is doing. So I will step in her stead. I'm sure I will leave some pieces out that that she might have included. A recent update, right at the end of November, the 30th of November, the Competency Restoration Work Group met with Disability Rights Washington. Don't know that folks are necessarily aware, but Disability Rights Washington is a private not-for-profit organization oriented towards protecting the rights of people with disabilities statewide. They're working in the True Blood process and had quite a bit of information. So really we're pursuing information from them just around funding and steps that have been taken within King County, and some of those components were the dynamics that we talked about in that particular meeting. a couple of representatives, Kim Mosseloff and Chris Carney from Disability Rights Washington, very informed individuals and just fairly connected to the processes that are going on. They did share that, just in general, that the True Blood settlement really has surfaced in sort of 3 phases. Those phases involve Southwest, Spokane, and Pierce regions, and implementation of services within those regions. And so they talked about that. They talked about more specifically, what we delved into was a program that I think that maybe we've touched base about before within King County called LINK, the Legal Intervention and Network of Care, which is a service that is a prosecutorial diversion program that provides behavioral health treatment in lieu of prosecution. So it's work with the prosecutors in that region and the services that are provided. It is a short-term flexible program in the region of 6 to 12 months. It is very oriented towards housing and providing housing. We all know how important those dynamics and aspects are, as well as behavioral health treatment, social services, case managers, legal coordination, access to psychiatric ARNP for prescribing, day treatment, peer support services, those kinds of dynamics. And we actually met, Barry Buchanan and I actually met with the LINK program folks just to really understand a little bit more about sort of boots on the ground experience and challenges that they face. So that is the most recent activity that the Competency Restoration Workgroup has been involved in. We don't have a meeting scheduled at this point. I believe we're going into January at this point, and I need to reach out to Barry to help and support that piece. I know that, and this is actually some of what Maya is involved in her meeting. We need to talk further about out of custody evaluations. Raylene had shared information previously that I just had put into additional topics that we need to touch base on in this particular group, as well as another challenge. If folks aren't aware, out of custody evaluations take a very lengthy period of time in order to occur. If I'm understanding correctly, there has been a prioritization of in custody evaluations, and that's part of the reason that out of custody evaluation is not occurring. I'm sure Raylene can talk more about this. She sent some examples to me as well, that the challenge with this length of time to wait for an evaluation itself, let alone getting the individual involved in some kind of outpatient competency restoration or assisted outpatient services, is another huge hurdle that we're dealing with. But those individuals without that availability of an evaluation and some kind of process are a very high risk to become involved with the legal system, during that period of time that they're literally awaiting an evaluation process. So those are some additional topics that we need to take a look at. And at least from my perspective, part of what is occurring is really looking at any short-term solutions that might be a possibility within Whatcom County, as well as looking at longer-term solutions of funding resources and how other regions or counties are putting together services and programs that can reduce the number of individuals that are incarcerated with competency restoration needs, et cetera. So yeah, hopefully that gives folks a pretty good sense of what's been going on in that group up to this point in time, and certainly is at the best of my ability answer any questions or comments.
Thank you, Perry. I don't see any hands up yet, but I was curious on what the effect of PCN closing is going to have on competency and restoration.
I can only share, sort of still collecting some information in that regard. Pioneer Center North had announced closure, and I think that most folks are aware of that. Actually, Pioneer Center North was slated to be closed over the last few years. The building is falling down, and that has been part of it. And if I understand correctly, the Skagit Port Authority is wanting to use that property for additional purposes, that sort of thing. Right now, they are going through the process of completing individuals' treatment or transferring individuals out. And if I recall correctly, the end of January is their last day of providing any services. And so one of the things that Pioneer Center North did, although I'll share that I don't know that they are officially certified to provide co-occurring disorder treatment services, they certainly build that and also had the ability to work with and to be aware of mental health issues that were occurring with substance use disorder issues. And so connecting the individual in terms of care coordination and resources that they needed. And that is somewhat unique in terms of particularly substance use disorder inpatient treatment facilities that are available across the country, across the state. One of the things that I will say, and this is just again from kind of my background as a substance use disorder professional, we commonly, if there weren't available beds for inpatient SUD services in the local area, we commonly did a bed availability review across the state, some preferred treatment agencies that worked well in terms of coordinating those systems and placed individuals in those locations. It's not preferable. Oftentimes I hear individuals say, well, their family can't visit them and the distance, of course, that they need to travel, which are all, certainly concerning, that the individual would get there and will get there safely and those kinds of things. However, sometimes it can be an advantage for individuals if substance use disorder is a component of their family. If there are dynamics there that can, bring up challenges. And so it's sort of a risk-benefit ratio that I continue to evaluate. And oftentimes for those individuals that would come back, they would come back to the facility that I was referring them out to inpatient treatment services. And I would ask them about that. Not all, but many would say, if there was a period of time in my treatment that I really had considered leaving. But the distance that I had to travel in order to do so didn't make it terribly simple. So I decided to stay, and I'm glad that I did, and some of those kinds of experiences. So definitely not the preference, but my point is that it opens some resources and availability as long as transportation is addressed within that issue. So I'm concerned about Pioneer Center North closure just in terms of availability within our local region. Obviously, I did reach out to, just out of curiosity, as I saw the information, there is a men's inpatient treatment program in Mount Vernon. It is run by Evergreen Treatment Center, and they have a 24-bed capacity at this point in time. And I actually just called them and said, hey, do you have available and open beds at this point? And they did. So that's not really a survey, obviously. I was just curious in terms of availability. I know that those challenges are there, and I was just sort of curious of an at the moment kind of process. So I think that that is a risk for us just in general, certainly relative to competency restoration and availability of SUD services, in that connection. So we have, and I don't know, Jackie may have talked about this, the North Sound Behavioral Health Administrative Services Organization is completing a needs assessment for the North Sound region. It should be, it's a very extensive, they contracted out obviously for that service, and it's a very extensive evaluation of needs relative to mental health and SUD services, inpatient beds, outpatient settings, that sort of thing. I've looked at some preliminary information, and I think that'll be really helpful for us to be able to review and many of the different committees. And so we'll make sure and bring that needs assessment summary and completion as it is done. So.
Thank you, Perry. Does anybody have any other questions for Perry? Well, I think this is a great segue into the next topic. I did want to mention that Barry did bring up some information on LINK. I thought it was a very interesting program. Didn't want to count it out, but thought that maybe we should work on making sure we had enough treatment providers before diving into something new. That was my take on that, but it's definitely something that we can bring up to another meeting if we decide we want to explore that further. But on that, we move to behavioral health workforce, and this is from the behavioral health committee's report and discussion. So I see Mike is still here. I don't know if Dan's popping in or out, but Mike Parker, do you have any information on that topic?
Hi, yes, I can get us started, and I see Stephen here as well, and I think there's kind of two parts to this, so I'll kick us off, and apologies if I need to head out. You'll probably hear it before I actually leave. So a group of us met, and just to recap this particular group, we invited Joe Valentine from the Behavioral Health ASO and Representative Alicia Rule to join a behavioral health subcommittee meeting. And one of our big discussion points was the behavioral health workforce. In that meeting, Representative Rule offered to really receive a wish list from the incarceration task force on those types of issues, specifically regarding workforce, but other issues in working with folks in our system who are behavioral health affected. So a group of us volunteered to meet outside of that. And there were really kind of two separate meetings. I'll let Perry talk about the one where he and some of his colleagues met with behavioral health professionals in Whatcom County. But a group of us, including Arlene, Stephen, some other folks met, and we really drafted essentially a punch list of, I think we ended up, Stephen can correct me if I'm wrong, with 4 particular items that really surfaced in our behavioral health subcommittee of the task force that we wanted to meet with Representative Rule on. Jackie, also from the county, was very helpful in getting us a meeting with Representative Rule, which if I'm not mistaken happens this Friday. And we also have a draft of a letter, thanks to Stephen Gockley, who drafted really that small work groups meeting and output together. And I don't know, Stephen, if we could share that screen, but that might be useful if folks haven't seen it. And then the last piece that I would offer about those particular points, and we can go over each one, but we took that to the steering committee, and what we wanted to do in bringing it to this group is to get more people to see it, and really to kind of get the full force of the task force behind it, so that when we meet with Rep Roll, we're keeping true to our form that we've taken it to our membership, and we're getting some broad consensus behind our points. With that, I'll go ahead and stop. And Stephen, if you wouldn't mind, if I could invite you to fill in the gaps of anything that I missed or maybe didn't hit accurately. Brian was also there, Jackie was there, and Arlene. So please, I will invite you all in.
Thanks, Mike. And Jill, would you be able to share the draft priorities list? Thank you. I'll just add to round out the discussants in that group, all of whom volunteered out of the meeting of this committee. It included Courtney Taylor as well from the Public Defender's Office. So I think this has been pre-distributed. And there's a paragraph of sort of introduction and rationale, trying to connect the behavioral health delivery system issues with our criminal legal diversion and treatment reforms. You know, if you can repair, you can't repair one without the other, or you can't repair our side of it in the task force without some actions that are beyond us locally in the behavioral health system. And we've been running into that repeatedly the last couple of years. So we wanted to start to identify some of those and list the ones that we thought might be either building blocks, you know, foundational stones on which other changes could be built, or fulcrum points that could actually catalyze some change elsewhere. You've all seen this. I hope you had a chance to look at it. Just in very brief summary, we started off with the point that we've been working on for a couple of years now, since the Crisis Stabilization Center was on the verge of opening, and that is to have some secure, ongoing, reliable operational funding mechanism, which hasn't existed. We've been operating largely because of the interest and effectiveness first of Representative Shoemake and in the first year's session, and Representative Rule has joined in on that support. But there are a lot of jurisdictions around the state that would like to have crisis stabilization centers, but we're not willing to make the leap of faith or the financial commitment Whatcom County was to dive in and commit operational funds to that. So that was our first point. We're looking for that kind of adequate funding mechanism for operational costs for crisis stabilization centers. The second was to try to increase the Medicaid reimbursement rates for providers, and building on Joe Valentine's report that the 7% funding increase from the last session piddled down through the trickle-down process that involves appropriations to the Healthcare Authority, and then appropriations and negotiations with the managed care organizations, down to the provider agencies through their administrative costs, and ended up with very little resulting in much of an improvement in the compensation to individual direct service clinicians and their supervisors. We wanted to try to target that. So you'll see some pretty elaborate, strategically chosen wording on that second thing. The third point came up when we realized that some people who are detained in the jail with obvious behavioral health needs and perhaps some willingness to access psychiatric prescription medications have to wait 6 weeks sometimes, and perhaps more, before the very limited contracted capacity for prescribing can meet with them and initiate medications. So we wanted to try to expand that. And lastly, looping back to the competency restoration problems, it's clear that the state agencies are glad to pay tens of thousands of dollars of fines for noncompliance with true blood mandates through state institutions like Western State. And so we wanted to allow at least some authority for locally created and provided evaluation and restoration services that might speed up the process and result in perhaps prevention, certainly reduction of incarceration. So at an appropriate point, I would encourage questions, discussion on these points. We do meet Friday with Representative Rule, and Jackie is working on a meeting time with staff for Senator-elect Shoemake as well, who's expressed interest in working on this list. I see Brian's hand up, and somebody else had their hand up earlier. Brian, why don't you go ahead?
Yeah, thanks for mentioning that meeting with State Senator-elect Shoemake. Believe it's been set for 4:15 to 4:45.
No, she changed it. Sorry, Brian. I thought I sent it out to everybody, but she changed it back to 3:45. So.
Okay. Thank you. My question, I guess, is with some of us who are going to be attending that meeting with Representative Rule and State Senator-elect Shoemake, were we getting together before those meetings?
That's a good question. We hadn't really addressed the process. For everybody's information, we have only 15 minutes set aside out of Representative Rule's schedule Mike Parker and I were going to talk tomorrow to try to plan out a strategy for presenting our points. My personal view is the more of our group that can attend, the better. Especially Jackie, you have some specialized knowledge that might be relevant to questions that come up. I don't see us having a free-for-all discussion in that
fine.
limited amount of time.
Yeah, that's fine.
So I think we need some fairly succinct presentation of these points and how we came to them. So I don't know what other participants in the work group think about that. I'm not trying to exclude people from having input.
No, I'm totally okay with that. And I had another issue I wanted to bring up. Did you want to discuss whether your plan is the best one?
Why don't you go ahead with your other point, Brian? And then
The other question I guess I had, and you know, in the draft on point number 3, I suggested we, sort of explain the significance of lack of timely prescriber availability. I guess in discussing this with the 2 electeds, my understanding is the jail is accredited by this National Commission on Correctional Healthcare, and they have some standards for mental health services. So I was just curious, not to complicate this, but are they meeting those standards? Does anybody here know what those standards are? And that would just be another way to kind of illustrate why this is such an important issue. So I just wanted to raise that question.
That's a great question. I see Jackie unmuted, so take it away, Jackie.
Well, yes, they are accredited by the National Commission on Correctional Healthcare and have been for probably 10 years, something like that. So it's been a while. And the National Commission comes in, I think, about every 3 years and conducts a review and audit of the services, and we have passed with flying colors each year. I think that they're probably about due to come in again. In fact, I'm not sure. I'd have to ask about that. The standards are mainly about timeliness for mental health, are mainly about timeliness of response, and we meet the timeliness of response. I think maybe they've taken into account the fact that the jail's a really horrible facility for anybody to be in when they conduct their audits. I don't know, but yeah, I would say what we have trouble with is providing a level of care beyond crisis services and good responses to people who need them. So if somebody's in there and they need more than a crisis response, they're probably just getting a very light touch at most. And then, of course, these days, a lot of people are leaving rather quickly out of the jail in unanticipated releases. Either the judge decides that they're good to go, or they've made bond. So a lot of times we aren't even getting to connect with them. So, they're going to be, I think, logistical issues no matter what happens in our future for how we drive the services and the quality of care that we can provide. As I was trying to say at one of our previous meetings, we are unable to provide a level of confidentiality that is usually required for mental health services because we're limited to talking to people at the hatch or talking over the phone. And so on one end or the other, there's always another inmate listening in to the conversation. And so what we really need are good confidential spaces in the new jail whenever it's built, in order to provide that quality of care that I think people require. You can imagine somebody with a serious mental illness who has delusions, some kind of paranoid delusions, and noticing somebody's milling about, listening to their conversation, and how that would limit the conversation. So just an example. Hope I answered your question, Brian. I don't know.
Thanks, Jackie.
Yes, thank you.
Arlene? You're muted, Arlene.
because we had a very long list originally of priorities, and these, of course, are extremely important, no question about it, but the others seem so terribly important to me that I asked permission to make an additional list of priorities, maybe to tag along. You could call it a minority report, perhaps, but it's an additional list of priorities that have to do with the workforce, yeah, which was a major focus. And so those priorities had to do with pay parity for mental health workers with other health workers, which addresses salaries and the importance of that. I do believe that there may be other groups and organizations that are going to be pushing for that issue. There are tuition reimbursements, training and supervision, and internship pay that was discussed. There were policy issues like cultural competency and diversity in the workplace to be emphasized. But in addition, there were some very important trainings that need to be required for staffing that we have, because we have so many people with co-occurring disorders that the cross training for law enforcement and mental health workers, or for SUD workers and mental health counselors, was important also, so that people should have the preparation to do this work and to do a good job of it. And that's the minority report.
Arlene, I want to take issue with referring to that as a minority report. I don't think there was anybody on the call that I was aware of who disagreed with any of the things on your list, and I would encourage you to have Jill distribute that to the group. It was just a matter of picking priorities, but also wanting to have our elected officials have that longer list for the more general course of their work during the session, the conversations they might have, the coalitions they might be building with other legislators on those issues. Everybody thought all of those issues were important, and we really appreciated your taking on the assignment of fleshing out a longer list that I hope we will be providing to our legislators.
Sounds good.
Stephen, if I could interject really fast, and my apologies, I gotta go attend to my small one who's squawking. But Stephen and I did set up a time. There were two things. One, Stephen, I know it's kind of an awkward spot for you, but I know you emailed, and we really would like to get some, just some general consensus, if we could, from this group of combined committees that this is a good foot forward. So I want to make sure that we do that. And Stephen, I got your email. The second thing I wanted to offer for getting together, I think Brian brought it up and Stephen has too. I think it's a good idea. We can use, I sent Stephen a Zoom link, and if folks are able to join us tomorrow, so I'm thinking Brian, Arlene, if you all are able to join at 3 tomorrow, that Zoom link would work. And we could certainly share that. So I'm sorry I won't be able to be here to see head nods, yeses or nos, but reach out to me on email, or Stephen, feel forward to forward that link. And I don't think it's a unique link. And we could use that for a time to meet tomorrow. And my apologies for being so in and out today. And thank you, Stephen, and everyone that was there for moving this forward. I think it's really important, and I'm very excited to be sitting down with both of our legislators about these priorities. I think it's a good tack for our task force to take with some of these things that we observe, we hear about, we learn about. And then I think the natural thing is, well, what can we do with it? And so I just want to make that statement that I'm very pleased that we're doing these things. Thanks.
So anybody who would like the link Mike sent me, I'll be glad to circulate it. And I agree with Mike welcoming Brian. Okay. And Raylene. And Mike's way too kind, giving me so much credit. Mike facilitated this discussion quite ably. And I just sort of put pen to paper, so to speak, on the consensus that came out of the discussion. But to follow up on his other point, we are meeting Friday, and somewhat in the guiding spirit of consensus decision-making, I'd at least like to see some indication that nobody objects strongly to this list being our talking points for those conversations. If anybody does have an objection to this list, you should speak now. Otherwise, we'll sort of start from here. And I think it's our hope that especially the graciousness of the invitation from Representative Rule in mind, that this will be the first of several conversations as the legislative session proceeds and as our conversations refining some of the practical implementation aspects of these points and others develops as well. So I hope this is the beginning and not a one-shot conversation. Is there anybody, I see your hand up, Raylene, so I'm going to call on you in a second, but is there anybody else who wants to raise your hand and speak with any concern about these points? And Raylene, I'm not trying to pigeonhole your comment. Go ahead. Oh, you're muted.
I muted myself. By all means, make sure that everybody has the opportunity. I looked over the list. I agree with the list. The only thing that I would like to make a comment on is number 1, and that's because we discussed it in the steering committee of the involuntary, which isn't really involuntary, drop-offs at the Ann Deacon Center for Hope. And I think if we want to continue on asking for funding and get assistance from legislation, I think more support is better. And if we can cut some of the red tape and try to figure out a way to allow law enforcement to use this more by having the involuntary where people aren't allowed to leave if there's on a 12-hour hold. I know there's red tape on that, but maybe that's something we can work on as a sub portion of this list. I mean, I think we want to do the funding, so I think that's the goal of getting this to legislation, but I don't want to get lost in the ability to use this to its best process. Thank you.
Stephen, Jill here. I just
Hi,
want I just want to note officially for the record that right now we're short of a quorum for both committees. So I don't I want anyone to infer that silence is official approval of the committees. So I just wanted to put that out there.
You're saying we do not have a quorum
For either committee right now, correct?
Okay, and so help advise me. I wasn't seeking a vote, affirmative vote to go ahead. I was seeking cautionary red flags from people that might hold up our process, which I would consider not a decision. Is that a fair hair splitting?
That is completely fine and fair. I just wanted to make sure again for the record that someone else who maybe listens to this after the fact or any of our folks here today don't make the assumption that your request is any kind of formal approval from the committees.
So noted. Perry.
I'm actually tagging on to something that Raylene had brought up relative to funding, specifically related to the Crisis Stabilization Center and the 12-hour law enforcement holds. I just wanted folks to, as a reminder, we did get proviso funding for 2022-2023 in the amount of $200,000. And I can just read the language just to make it as clear as possible. The North Sound contract with the North Sound Behavioral Health Administrative Services Organization to establish Whatcom County Crisis Stabilization Center as a pilot project for diversion from the criminal justice system to appropriate community-based treatment. The pilot shall allow for police officers to place involuntary holds for up to 12 hours for persons placed at the facility in accordance with RCW 1031-110, The amounts provided must be used to pay for the cost of services at the site not covered under the Medicaid program. So I just wanted to bring that point of clarification that there are some funds. Obviously, we talked about this a little bit, that in terms of getting the certification, which was necessary prior to, then once the certification had been obtained by Compass Health, who offers the mental health services at the facility, did achieve the state certification for that. And then a requirement within that certification was additional staff, which they actually hired and are in the process of training now. And so just wanted to make sure that that piece of information was available to the committee, and that was my purpose.
You know, Perry, I'm not sure we talked about that, but I think I must have made an assumption that the committee knew, because I was thinking the request was about permanent funding, and that you were hoping that we wouldn't have to pass a proviso each year in the governor's budget in order to make sure that we had stabilized funding. Stephen, that's what I thought your intention was when you wrote it. So I could be totally wrong.
No, that was the intention. At the same time, I don't think, as a general rule, most of us were aware of that proviso that you just read, Perry. So thank you for adding that. Raylene, to your point, this came up, and I think it was a little bit surprising to the steering committee members that involuntary could mean something different than probably what most of us thought in terms of enforceability. And so I think most of these reflect things that we have long discussed and identified as priority needs. I think that's something that the involuntary hold capability and how that's actually carried out or not might be something that would be good for us to vet a little bit more through our meetings and discussions and deliberations. I think we can talk about it with this on Friday and beyond. So I definitely think that's something we should explore and put a finer point on. I'm not sure about rewriting this right now, a couple of days before our meeting, to include that.
Stephen, I don't think this needs to be rewritten. I think it's just something that I wanted to make a point that we explore in the future. I think there was some surprise to that. I also, after talking to law enforcement right before the steering committee, from 4 different jurisdictions on their lack of use of the Crisis Stabilization Center due to the fact that the people could walk away, so they didn't really feel like it was an option for them to use, and that they were going to use the hospital or the jail over this option, and that's not always a possibility either when there's restrictions on booking. So there was definitely concerns from law enforcement on what they could do. And so I just kind of wanted to make sure that that didn't get lost in this, but I do think we should move forward with what's on here, minus the quorum.
Great. Thank you, Raylene, for that clarification. I completely agree with you not to lose that. I think that's going to get a good bit of attention in the discussion about how the Crisis Stabilization Center is serving the community in the near future. So I didn't see any objections. We'll report back on these discussions with Representative Rule and Senator Shoemake. Brian and Raylene, I'll forward you that Zoom link from Mike. And thank you all for paying attention to this priority list. And Arlene, I think you have sent your list to Jill. Jill, if you could send that around to the rest of the committee members, I'd appreciate that as well. Back to you, Raylene.
Thank you, Stephen. Thank you, everybody, for participating today. Do we have any other business from any of the members? Oh, it's quiet again. other business that I'm just going to bring up because it's so quiet. I'm always happy when things go a little bit quicker than needed. But it was brought up to me by some other chairs and members that sometimes we don't get the active participation and it's quiet. And then we end up calling on people at different committees, and it's not just ours. Our law and justice or behavioral health, there was index committee concerns too, that we want everybody to be able to participate. So please don't be afraid to use your voices as we move forward. That was just a side note. Otherwise, seeing no hands, I think we can move to Jill for public comment.
Thank you. We have a few attendees virtually at the meeting right now. If you would like to speak to the committee, please virtually raise your hand. And no hands are raised, and it looks like we don't have any attendees in our conference room at this time.
Well, thank you.
I'll just announce that I have resigned my position with the health department as of January 3rd. I see Eileen's face. And it's, you know, with a lot of mixed feelings that I do so. And but I wish you all well. It's been great being on this committee. I actually have learned a whole lot from you folks, and I hope to see you somewhere in my future. Like,
I don't know what to say, Jackie. I'm just at a loss. We're losing
Yeah.
Where are you going?
people.
oh boy, well, I'm going to work for direct services for a statewide organization that does direct services remotely. So yeah, who knows how it'll work out. Maybe I'll be back before you know it. You just, you know, I just needed to turn away and do something different. So
Jackie, for one, thank you for your service and for everything you've done for this committee, but for everything else that you've done too. And yeah, I had to pop back in because I heard that from the other room where I was with my little one. So that's how I feel, but I'm happy for you and sad for us. And I'm sure that they'll recruit and try to get somebody in your position. Anyways, just thank you. Thank you for all that you've done and do and for who you are.
thank you, Michael. Appreciate that.
I'll double down on both of Mike's points. I'm happy for you, and you've been an extraordinarily valuable participant for years and years. That's really advanced the task force's work, and I'll miss working together.
Thank you so much, Stephen.
I think respect and appreciation are noted around the room. So thank you so much, Jackie, and good luck on your future.
Thank you. Thank you, Raylene.
With that, no public comment, no other notices. Thank you again. I'm sure we'll see you again soon, Jackie. Have a great day. Thank you. We're adjourned.